I've got everything prepped already and this is non-sterile. I think it's a good idea to use the central venous catheter insertion new sheet, which was produced in 2023, which has got on it is the CVP waveform present and the CVP recorded as part of the during procedure and sign out of the procedure, not of the operation, because you need to know this before you start using the neckline. So I think one of the things that would be very useful is if we start using this as a stop before you put a CVP line in moment as well. The reason for this checklist is not only to remind ourselves that the transducer is ready, so if you can just show us that the central line transducer is already there, all ready to go, but it's also to remind us which bungs, and not only which bungs, but that the bungs are attached firmly, because there have been incidents where they are loose and you can either get an air embolus or the patient can bleed out. The big thing about using the ultrasound for necklines is that you want to combine the landmark technique with the ultrasound technique. And I know a lot of people don't get trained in the landmark technique these days, which is why it's always good to be able to confirm before you put your probe on that you know where you're going. What I always do, once the patient's prepped and ready, is I check the landmark technique, so I know where I'm going. Sternal notch with one thumb, mastoid process, and then imagine a line drawn between the two. Halfway along that line is the high approach to avoid a pneumothorax. Where your finger is marking halfway, you're going to check for the carotid pulsation, and then you're going to use your fingers to flatten the internal jugular vein, and as you release, you can see it refill. If I do that again, you can see the internal jugular vein here. So now I know where to put my probe. Before I put my probe on, I can do it again. Sternal notch, mastoid process, halfway along, keep a finger there. Just checking that I've got the right side of the probe with the right side of the screen. Really important is to have your little finger as a solid, stabilising placement. So I'm going to place it on the sternum or clavicle. As I put my probe down exactly on the spot where I thought the vessels were going to be, this is what we get. So I'm going to turn the screen a little bit deeper there. So sternomastoid on top, big vessel. It's not always big, but usually it is. Pulsatile, smaller vessel. You can clarify that by pressing, the vein occludes. I've got my little finger on the sternum and the ultrasound probe held vertically. I think this is possibly one of the most important things about using the ultrasound technique. When combined with the landmark technique, our needle still needs to be heading towards the ipsilateral nipple. So if you put the probe on like this, then you're heading towards the artery. If the probe is vertical and you're able to head towards the ipsilateral nipple, you're much less likely to hit the artery. So really focus on having the vein in the middle of the screen. There is a cannula, the set. You can then thread the cannula and have the cannula only in the vein. So keeping the probe vertical, and then when you have your needle approaching, you want to stay in line. Us to be seeing on the screen what we're actually doing in real life, we need to have the needle in line with the probe, not like this, not like that, in line with the shaft, so that when you're going through the vein, seeing on the screen what is actually happening. So that's all lined up. You're heading towards the ipsilateral nipple with the needle tip, not in the neck here. So you have a look on the screen there, you can see that you still get a good view when you've got the probe pointing at the neck like this, but you're also pointing directly at the artery with your needle when you go in. So vertical probe. If you are going to use the cannula, it's a new learning curve completely, but once you get used to it, you're able to take a gas off it if you're unsure, and you're able to transduce it temporarily and then take it off again onto the cannula. So those are two benefits of using the cannula. So as you are advancing the needle through the skin into the vessel, you can tilt the probe to keep an eye on the tip of the needle as it enters. You'll see the deformation of the tissues as the needle starts entering. When you're threading the wire, and you've taken out your rigid needle or cannula and you just have the wire in the vessel, you can then turn the probe longitudinally to bring the vein into view like this, and you'll then see the wire entering the vein and running down towards the heart. Important things are transducing before you use the neckline, using a combination of landmark and ultrasound technique, making sure that the probe is vertical, that your needle tip is heading towards the ipsilateral nipple to stay away from the artery, and then checking that the wire is in the vessel before you then dilate and introduce a larger cannula into the vessel.